There are topics which are given by National Medical Commission itself. So some 6 to 8 topics are given. So first topic, which is a very interesting topic, is ischemic heart disease that we have chosen. And the notice was circulated in all the groups to the students also regarding this topic. So I hope that, or I expect from my students, that whenever there is activity on any academic topic, it is your responsibility that you should go through the topic and come prepared for the seminar. So I hope that students from IIMSR, they must have taken some efforts to go through the ischemic heart disease and come prepared so that they have better understanding of the topic. कोई है इसमें ऐसा जिसने ये टॉपिक पूरा पढ़ लिया है? Is there any sincere student? Last Sunday we had one program in Hajj House, Dr. Abdul Majid, renowned neurologist from Aurangabad, who has completed 1 million consultations of neurology in last 20 years. He said that no one is ideal, no one is ideal, but sincerity can be there. So if you are sincere enough, you will go through the topic and you will come prepared. I expect from you that you should go through this topic from anatomy, physiology, biochemistry, pharmacology, pathology, medicine, community medicine. These are the subject areas which this topic covers. So our students are supposed to go through all these topics and come prepared. But I congratulate all the presenters. They have taken efforts to take part in this seminar. Still one presenter is struggling in the preparation of the PPT. So you can just imagine how much efforts are being taken by the teachers to teach you. It is not so easy that a teacher comes here and delivers the topic. We need to prepare. We need to spend the time. Then come prepare and take your lecture. And what happens? 50% of the class is absent from the class. Yeah? So that is very disappointing for the teachers. So I hope that this seminar is going to stimulate you all, because this will be every month we will have, and I have a plan that if there are all 5 batches, this program will be conducted in the auditorium if management permits. And they have promised, Mr. Madam promised that auditorium will be given to you, and you will present in auditorium, inshallah. So to start with this seminar, I invite Ischaemic from the JIIU batch. Her topic is anatomy of heart, blood supply. So please, I request all of you, please maintain the discipline so that presenters can present the topic in a nice manner and you can enjoy this academic piece. So I request everybody to maintain the discipline while the presenter is presenting the topic.
the two branches, that is the left anterior descending artery and the left circumflex artery. The left anterior descending artery is further divided into the different branches, that is the diagonal branches and the septal branches. The diagonal branches supply the anterior and the lateral wall of the heart, whereas the septal branches give branch to the septum. Now, moving towards the dominance. Dominance can be explained with respect to the posterior descending artery. Right now, I just explained you the posterior descending artery is a branch of the right coronary artery. So, if the posterior descending artery is arise from the right coronary artery, then it is called as the right dominance, which is present in 80 to 85%. But if the posterior descending artery is arise from the left circumflex artery instead of the right coronary artery, then it is called as the left dominance, which is present in 10 to 15%. Now, the ischemia can occur because of the occlusion of the coronary artery. So, the occlusion can be present in the right coronary artery, or it may be present in the left coronary artery. So, if the right coronary artery supplies the right wall of the myocardium, the inferior wall of the myocardium, and the some part of the posterior wall of the myocardium. So, if the occlusion present in the right coronary artery, it leads to the right wall myocardial infarction, the posterior wall myocardial infarction, and the inferior wall myocardial infarction. But if the occlusion present in the posterior coronary artery, so the posterior coronary artery supply the anterior wall, the lateral wall, and the septum. So the occlusion may lead to the anterior wall myocardial infarction, the lateral wall myocardial infarction, and the septal wall myocardial infarction. Now, moving towards the right coronary artery occlusion. So the occlusion are present in the two places. The proximal to the occlusion can be present in the two places. Proximal to the left right marginal artery, then it is called as the proximal occlusion. And if it is present behind the right marginal artery, then it is called as the distal occlusion. So if the proximal occlusion is present, it leads to the involvement of the right marginal artery as well as the posterior descending artery. So if the right marginal artery is involved, then it leads to the right wall myocardial infarction, and if the posterior descending artery is involved, it leads to the inferior wall myocardial infarction. But if the occlusion is present behind the right marginal artery, इसके पीछे present होता है, तो it leads to the only inferior wall myocardial infarction because it involves only the posterior descending artery. The right marginal artery is spared. Now moving towards the dominance. Just now I explained you the dominance of the proximal occlusion and the distal occlusion of the right coronary artery is the right dominance. But in the left dominance में क्या होता है कि left dominance में posterior descending artery arise from the left circumflex artery, but occlusion present in the right coronary artery. तो यहाँ पे जो proximal occlusion होगा, तो proximal occlusion only involve the right wall myocardial infarction because it involve only the right marginal artery. यहाँ पे proximal descending artery right coronary artery से arise नहीं हो रही है, तो इसलिए distal occlusion में there is no myocardial infarction. Now, moving to occlusion may lead to the ischemia, which further leads to the infarction. So, the inferior wall is supplied by the right coronary artery and the left circumflex artery. The occlusion present either of them, the right coronary artery or the left circumflex artery, it leads to the myocardial infarction. And the changes seen in the inferior lead, that is the lead 2, lead 3 and the AVM. But my question is कि right coronary artery भी सप्लाई कर रही है और left circumflex artery भी सप्लाई कर रही है, तो अगर inferior wall हुआ है तो कैसे पता चलेगा कि whether the right coronary artery is occluded or the left circumflex artery is occluded? So here दोनों में ST elevation मिलेगा 2, 3 and the AVF में. तो यहाँ पे अगर if the right coronary artery is occluded, so there is more ST elevation in the segment lead 3 than that of the lead 2. But opposite होगा left circumflex artery में. अगर left circumflex artery occluded है तो ज़्यादा ST elevation मिलेगा in the lead 2 than in the lead 3. Now अगर ये diagnose हो गया कि right coronary artery occlusion है, but right coronary artery occlusion में present in the proximal occlusal. So if the proximal occlusal is also present along with the inferior wall myocardial infarction, then it indicates that the proximal occlusal are present in the right coronary artery. But एक यहाँ पे प्रॉब्लम होता है कि 12 ECG में राइट वॉल के चेंजेस इंडिकेट नहीं होते हैं, तो कैसे पता चलेगा कि राइट वॉल इन्वॉल्व हुआ है या नहीं? तो सी द चेंज इन द V1 एंड द V2. V2 एंड V1 में दोनों में ST सेगमेंट एलिवेशन है, बट देयर इज मोर ST सेगमेंट एलिवेशन इन द V2 देन इन द V1. इट इंडिकेट्स द राइट वॉल इज आल्सो अफेक्टेड. तो फिर हम लोग एक्स्ट्रा लीड लगाते हैं V3R, V4R एंड V5R इन द राइट चेस्ट वॉल, and it indicates the ST segment elevation in the V3R, V4R, V5R and V6R, that the right wall is also affected and there is a right wall myocardial infarction. Then in the posterior wall, same happen in the posterior wall myocardial infarction. The posterior wall myocardial infarction changes doesn't appear in the 12 ECG. तो कैसे पता चलेगा कि posterior wall myocardial infarction हुआ है या नहीं? So there is ST segment depression in the V2 and the V3. See here, there is ST segment depression in the V2 and the V3. तो आगे के जो चेस्ट लीड होते हैं V3, V4, V5 and V6, उसको हम लोग पोस्टीरियर चेस्ट वॉल में लगाते हैं और नंबरिंग करते हैं एज अ V7, V8 and V9. V7, V8 और V9 का ST segment elevation मिलता है. Then there is also involvement of the posterior wall and indicates the posterior wall myocardial infarction. Now moving towards the left coronary artery occlusion. तो लेफ्ट कोरोनरी आर्टरी occlusion में left anterior descending artery it gives a different branch. The first diagonal branch it gives to the high lateral wall. So the high lateral wall and the high lateral lead is the AVL and 1. So if the occlusion present in the D1, so the ECG changes seen in the AVL and the 1 lead. If the occlusion present in the S1, because S1 supplies the septum and the septal lead is the V1 and the V2. So there is ST segment changes seen in the V1 and the V2 indicate that the septal wall is occluded. If there is changes present in the D2 segment, we supply the anterior wall and anterior lead is the V3, V4 and V2, V3 and the V4. So if the ST segment changes indicates changes seen in the V2, V3, V4, there is an anterior wall occlusion is present. Same here, V3 supplies the lateral wall and the lateral lead is the V5, V6. If the changes seen in the V5 and the V6, it indicates that the V3 segment of the left anterior descending artery is occluded. Now the last is the left circumflex artery. Left circumflex artery is like the left coronary artery. और मैंने अभी बताया कि there is लेफ्ट सर्कमफ्लेक्स आर्टरी इंफीरियर को सप्लाई करता है, पोस्टीरियर को सप्लाई करता है. तो अगर अक्यूजल होगा तो there is an inferior wall myocardial infarction as well as a posterior wall myocardial infarction. तो inferior wall myocardial infarction होगा तो lead 2 में ज़्यादा ST segment elevation मिलेगा than that of the lead 3. It indicates that the left circumflex artery is occluded. So that's it from my side. Thank you so much.
So that was excellent presentation by Aisha. She has covered not only the blood supply part along which she has showed changes which are taking place because of the occlusion of the religious coronary arteries and leading to the myocardial infarction. I remember when I was doing my post-graduation, I was working in Nagpur, IIMSR Cardiac Care Center. Dr. Uday was the first cardiologist from Central India, and he has opened a cardiology center. And there I heard, and there my posterior wall, and the diagnosis used to be very long. ISD, diabetes mellitus with hyperlipidemia, and so on. In the morning we used to give some 10 to 15 tablets to the patient as a breakfast. So that is all because of the lifestyle we are living. So ISD is also related with this lifestyle. So we need to modify our lifestyle so that we should not suffer from ISD in the future life. Now let me introduce the judges for today's seminar. Dr. Sachin Sarvade, the Professor at Department General Medicine, Dr. Jalna, Professor of Medicine, and Dr. IIMSR, Professor of Medicine. These are the judges for this seminar, and we have the competition that best three presentations will be awarded at the end of this seminar, and all the participants who have taken part in this seminar will be given the certificate. Now I invite second speaker, that is Ischaemic from 2021. Action potential and cardiac cycle. This is our topic. The time allotted for presentation is actually 8 minutes, but we are extending it to up to 10 minutes. So first bell will ring at 8 minutes, and second bell will ring at 10 minutes, and afterwards there will be no bell. Afterwards there will be no bell. First bell at 8 minutes, second bell will be at 10 minutes. So you should understand that you have crossed the limit of the time presentation, because the points are given for the time limit which you are taking for your presentation. So Ischaemic from 2021 batch.
Assalamualaikum and a very good morning to everyone. My name is Ischaemic and today I am going to present a seminar on action potential and cardiac cycle. So, action potential is a series of changes that happens in the voltage difference across a cell membrane. This action potential, basically the cell is at the resting membrane potential. The resting membrane potential of the cell is negative because of the gradient in the concentration of positive and the negative charges. For example, that the sodium and calcium is in high concentration outside the cell, and potassium is in high concentration inside the cell, which the net difference of the ions is more positive charge outside the cell and less positive charge inside the cell, which leads to the negative resting membrane potential. Now, throughout the action potential, what happens is there will be inward and outward flow of the ions that happens through these ion channels. Now we know in the heart is made up of cardiac myocytes. Now these cardiac myocytes are of two types. One which generates the impulse like ECMO, another which is through the contraction like the contractile tissues. Both of these tissues performs action potential. This is the action potential of the SAO that generates the impulse, and this is the action potential of the contractile tissue which do the contraction. Both of these, the pattern of both the action potentials are different. So let's study about that. So first we'll study about the nodal tissues. In nodal tissues, there are three phases: spontaneous depolarization, depolarization, and repolarization. First we'll look at the resting membrane potential. The resting membrane potential of the nodal tissue is minus 60 millivolt. What happens? There is something called as funny channel. This funny channels led to the entry of sodium from outside the cell to inside the cell. Now the positive ion is coming inside the cell. This will lead to the increase in the membrane potential, and that's why there is a slight increase in the membrane potential of the cell. Now the membrane potential of the cell reaches to minus 40 millivolt. This minus 40 millivolt led to the closure of the funny channels and opening of the allocated calcium channels. Now allocated calcium channels opens at minus 40 millivolt, which will lead to the all these cells are connected through the gap junction. This gap junction will allow the flow of cations, that is sodium and potassium, from one cell to another cell. Will allow the flow of ions from one cell to another cell, and as the ions are flowing, it will stimulate the ion, it will stimulate the cell and perform the action potential. So we will see the action potential of the contractile tissue. The action potential of the contractile tissue consists of 5 phases: phase 0, phase 1, phase 2, phase 3, and phase 4. So phase 4 is the resting membrane potential phase, which means the contractile tissue of the cardiac myocytes are at minus 90 millivolt. Once through the gap junction, the ions flow inside the cell. When the ions flow inside the cell, the cell gets stimulated and there will be a slight increase in the membrane potential. This slight increase in the membrane potential will lead to the voltage difference of minus 70 millivolt. That is the threshold voltage. Now, once the threshold voltage is reached, voltage sensitive sodium channels opens. At minus 70, voltage sensitive sodium channel opens. This will lead to the entry of sodium ions inside the cell, and that's how it will increase the membrane potential. And again, the membrane potential, as there is entry of the positive ions inside the cell, there will be increase in the membrane potential, and the membrane potential will lead up to plus 20 to plus 30 millivolt. At plus 20 to plus 30 millivolt, sodium channels get inactivated, and this marks the depolarization phase of the contractile tissue. Now, at plus 30 millivolt, potassium and elevated calcium channel opens. Once the potassium channel opens, it will lead to the outflow of the potassium ions. This will lead to the slight decrease in the membrane potential, and this case, when we see there is a slight decrease in the membrane potential, is called as the phase 1, that is early depolarization phase. Now, calcium channel opens, elevated calcium channels will lead to the entry of calcium ions, and the calcium channel will lead to the outflow of potassium ions. Now, this both will maintain an equilibrium, and that's how the contractile tissue will maintain an equilibrium of 0 millivolt, and it will be at flapping phase. Eventually, calcium channels will close and potassium channel is only open, and which will lead to the outflow of potassium ion, that is there is an outflow positive charge, which leads to the decrease in the membrane potential, and ultimately the membrane potential leads to minus 90 millivolt, and that's how the cycle repeats. Now we'll talk about what happens in ischemia. As we see, there is difference in the pattern in ischemic heart as well. Now there are 3 major differences that is seen in ischemia. The first one is there is less negative resting membrane potential. Another difference is there is unslope. The unslope will be slower, and third will be there is a shorter duration of action potential. So there will be less negative resting membrane potential is due to because ischemia, what happens in ischemia, there will be decrease in oxygen. Due to decrease in oxygen, there will be less in ATP supply. Because of less ATP, sodium, potassium ATPs will be inactive or very less active. This will lead to hyperkalemic condition, and that's how the resting membrane potential changes, and which will lead to increase in the membrane potential and less negativity of the membrane potential, which is minus 60 to minus 70 millivolt. Then it happens unslope will get slower. That is because normally what happens, the sodium, once the sodium channel opens, sodium is rapidly entering in the cell. But in ischemic condition, there will be slow and shorter, less entry of sodium. That's why the slope will be shorter and the duration of depolarization will be higher. Then the duration of action potential is also reduced to reduce the energy consumption in this cell cycle. These are the differences of ischemic heart. Now we'll talk about the cardiac cycle. In cardiac cycle, there are though ischemic heart disease is not directly related to cardiac cycle, but to understand any disease, we should first know the basic mechanism. So in ischemic heart, there are various phases. First is atrial systole. In atrial systole, what happens is atria is contracting, mitral valve and bicuspid valve are open, there will be a flow of blood from atria to ventricle, and centrifugal thereby the ejection of the blood from outside the heart. Then the ventricle will relax. For the relaxing of ventricles, semilunar and close, there will be decrease in the pressure, in the intraventricular pressure. But there is no change in the volume signals. It is also known as volumetric relaxation phase. Then talking about this phase, where the mitral valve open, here the atria is receiving as well as getting the blood into the ventricles. Therefore, it is also known as diastasis phase. And again, the cell continues with cell cycle. There are few changes that happen in cell cycle. That is, due to decrease in the action potential, there will be prolonged isovolumetric contraction and isovolumetric relaxation. There will be certain systolic dysfunction, for example, the heart will not be able to counter properly, so there is decrease in ejection fraction, there will be decrease in cardiac output, and in diastole, the heart will relax for a longer time, so that's why there will be increase in end-diastolic volume and that's it.
Excellent presentation by Ms. Rashid. She has very nicely explained the cardiac cycle and the action potential involved in the ECG formation and how the various waves are affected because of the action potential and mitral function. So I request all of you, please give a big round of applause for all these presenters. Now next we have Ms. Fatma from 2022 batch. She will talk on the biochemical markers of myocardial infarction.
Biochemical footprints of the cardiac injury. These are nothing but our biomarkers. These are the early alert system that sets in even before the ECGs and the symptoms. So behind the scenes, what happens is whenever there is an atherosclerotic plaque rupture in the blood vessels of the heart, there is formation of the thrombus, and this thrombus leads to decrease of the blood flow to the heart. That is nothing but the ischemia, and this ischemia leads to ATP depletion within 1 to 2 minutes, and hence there is enzyme leak due to cardiac damage, cardiac muscle damage, and these biomarkers reflect the extent and timing of the damage. So what are biomarkers? These are biological molecules which are found in blood or other fluids or tissues, and these are the signs of normal or abnormal conditions or disease. So the importance of biochemical markers is helps in early diagnosing and managing the infarction. Without them, they can be a challenge to diagnose MI easily, and also there is limitation to the traditional diagnostic tools like ECGs can only detect 50 to 60% of the ST elevated MI. hours to confirm an ongoing injury. Then there can be elevation of the troponin even without the MI in cases of sepsis, trauma, renal failure, pulmonary embolism, heart failure, myocarditis, and stroke. Then we have very important high sensitivity troponin rule in and rule out protocol. Given by the ESC guidelines, there is 0.1-hour protocol and 0.3-hour protocol. So understanding it is very important that if at 0th hour the patient has a baseline levels of the troponin, but after repeating after 1 hour, it increases above the baseline. Or after repeating after 3 hours, it increases more than 20% of the baseline. Then we can claim it as acute myocardial infarction, and it is used in emergency room triage and chest pain clinics. So this is the criteria for acute myocardial infarction for type 1, type 2 and type 3 infarctions. There should be compulsorily rise of troponin levels along with any one of these features. There should be either a symptom of myocardial infarction, there should be either a new ECG chain or a pathologic fluid. Then we have creatine kinase muscle band. These are found in skeletal muscle as well as cardiac muscle, and these are less specific than troponin, but these are really important in detecting re-infarction or the re-rise of the second spike of the infarction. Hence, we can't take the patient after this, from the OPD. These are also found. These can be also falsely positive in muscle injury, surgery, and marathon runners. These have a diagnostic threshold of more than 19%. Then we have myoglobin. These are the earliest biomarkers. These rise within 1 to 4 hours of the cardiac damage, but these are not specific to cardiac muscle. Hence, we don't use it that much. But when used in conjunction with the other biomarkers, they can be really helpful in diagnosing MI. These can also be falsely positive in trauma, crush injury, and seizures. Then we have LDH. These are now outdated because these are very low specificity, but the LDH flip ratio is really important. Whenever in the bloodstream the LDH1 increases in LDH2, then it can be suggestive of MI. This is a quick comparison of all the biomarkers. As you all know, troponin rises within 3 to 6 hours. It is the gold standard. It is the heart's 911 call. Then we have CKMA, which is important for infarction. Myoglobin is the earliest biomarker, rises within 1 to 4 hours. And we have LDH, which has importance of its flip ratio. Then we have some minor or supportive biomarkers like lipoprotein A, which indicates the increasing risk of the atherosclerotic diseases. Then we have high sensitivity C-reactive protein, which are indicative of inflammation caused by atherosclerotic diseases. Then we have P-type natriuretic peptides, which are indicative of heart failure or ventricular strains. Then we have some newer biomarkers in market, like copeptide, which is released with vasopressin, or hard-type fatty acid binding protein, which has better sensitivity than myoglobin, and also GDF15 and microRNA. These are all experimental and predictive. These are not used. So what do doctors do with this information about the biomarkers? This helps us in doing early prognosis of the patient. Like as soon as the patient comes with the biomarkers, we'll start with the thrombolysis, we'll start with the PCI, percutaneous, coronary intervention like angioplasty, stents and all those stuff. And also detecting the infarction will make sure that the patient is not having the second spike of the infarction. Then also the PSA part of the biomarker is that in India, ischemic heart disease burden is rising. It is as much as 28% of all the deaths. So there is a very important test called troponin-based point-of-care testing, which are used in rural settings or mobile cardiac units in India under the IIMSR pilot project. So it reduces the door-to-needle timing and potential in mass screening and rural care, and decreasing the mortality rate, decreasing the economic burden. Here's a case scenario of 52-year-old diabetic male with chest discomfort and sweating for 1 hour. So instead of MI, and what's the protocol? So obviously it is MI, discomfort and chest pain and all that, but the protocol is ruled in 0-1 hour protocol. As you all can see, at 0th hour, 0th hour पे 0-1R protocol. And biomarkers does not only help in diagnosis, they help in dictating the urgency, informing the prognosis, and optimizing the outcomes. The clinical contacts may be the thing in IHD, but the biomarkers or the enzymes are the core advisors. They help in advising. So how to further? This is the rapid fire for the audiences. What is the earliest marker to rise after myocardial injury? Yes, myocardial rises within 1 to 2 or 1 to 4 hours. Which marker stays elevated the longest? 7 to 10 days it stays elevated within the time. Then third is 0-1R period, we have to have it more than baseline, that is 5 to 10 nanograms. These are the references that we use. Thank you.
Very nice presentation by Ms. Jalna. She has covered not only the biological markers but also the community medicine part and the screening of ISD in the community by performing test also. So I think that now you are clear with the biochemical markers. They are more important than the investigations of ECG or clinical expertise along with the biomarkers to direct the root of the disease management. So that was a very nice presentation from Ms. Jalna. Now next we have the presentation on the pathogenesis of ischemic heart disease, and that will be delivered by Mr. Faruqi from 2022 batch. So we have 10 presentations today. We are starting from anatomy till the complications, management and prevention of ischemic heart disease. So pathogenesis is one of the very important part that it will tell you how the disease evolves. Whenever a person gets the coronary occlusion and how the symptoms they are developing, how the ECG changes are taking place, and what are the things which are happening at the myocardial level, because we know that one attack, second attack, and then the third attack patient is gone. Because we know that once the myocardium is dead, the tissue will not recover. Which is the next issue in the body once it is dead, is it will not recover. Body में ऐसा कौन सा issue है, once it is dead, it will not recover. Which organ? Which organ? Brain. Brain is the organ. Okay, so now over to Ms. Jalna.
Good morning and assalamu alaikum everybody. My topic is pathogenesis of ischemic heart disease. Now obviously you see a patient coming to me and से गिर गया. अब आपको पता चले ना उसका pathogenesis क्या है, ताकि उसको treatment और directly find करो, ठीक है? So what is ischemic heart disease? It is an acute or chronic form of cardiac disability between possible imbalance of myocardial oxygen demand and low oxygen blood supply. So there will be increased myocardial oxygen demand and there will be low blood supply. This can be due to formation of plaques. Mind you, this is not your teeth plaque, this is the actual real teeth, which is the plaques in your heart. Now you see all the countries covered in red over here. They have the highest incident cases of ISD. That is ranging around from 40,000 to 3 million annually. This is just the incidence. Now we move on to prevalence. For the prevalence, ISD remains the leading cause of death worldwide. Let me tell you, it even surpasses cancers. Over 400 million people globally have ISD. More than 9 million deaths occur annually. It also ranks first in disability adjusted diagnosis. Now, in order to understand the pathogenesis, we first have to see the risk factors. They can be modifiable, that is, those which can be changed due to your lifestyle. For example, smoking, hypertension, hyperlipidemia, diabetes mellitus, obesity, poor diet, psychosis, stress, etc. And sadly, non-hormonal cannot be changed, like age, sex, genetic factors, familial factors, racial factors, etc. Now we also have emerging risk factors. These are use of exogenous hormones, metabolic syndrome, anemia, inflammation, impaired glucose tolerance, and then we have comorbid factors. Okay, now we begin to move on to the main topic, which is pathogenesis. We covered under three subtopics, that is coronary atherosclerosis, superadded changes in coronary atherosclerosis, and non-atherosclerotic bodies. First of all, coronary atherosclerosis constitutes for about 90% of the cases. The remaining 10% of the cases, they are due to other causes, but 90% it is a related. So arteries commonly affected, like what is the heart rate trial. You see first of all there is left anterior descending artery, which is seen affected in about 40 to 50% of the cases. Then we have right coronary artery affected in about 30 to 40% of the cases, and then finally we have the left circumflex artery affected in about 15 to 20% of the cases. Now the most important topic, development of atheroma. So it all begins with a small endothelial injury, which you may think is not that significant, but yeah, here it plays a very important role. You see, this is a normal artery with a normal lumen, endothelium, intima, media, everything can be seen very clearly. So endothelial injury is caused by hyperlipidemia, hypertension, smoking, etc. Mainly in our population, we see those two main contributing factors. They are hypertension and chronic hyperlipidemia. So they cause this endothelial injury over here, and then let's take the aggregation and monocyte migration. Obviously, they will come to the rescue, alright? Then you see the monocytes divide into macrophages. These macrophages and platelets, they will release cytokines like interleukin 1 and human necrotic factor alpha, which will help in the smooth muscle cell proliferation, and they will also help in ECM, extracellular matrix production. Alright, and then we will also release platelet-derived growth factor and fibrous growth factor, which will cause migration of smooth muscle cells from media to the intima. Then, as you can see, due to hyperlipidemia, plasma LDL is already circulating in our bloodstream. So this LDL will stick inside the intima over here. Macrophages will come and eat it, and then they will become lipid-laden cells. So you can say macrophages became for fighting for the immune system, and then they got laid back by the snacks. Alright. Then the smooth muscle cells will enter the lipids. This lymphocyte doesn't go over here, it will regulate the collagen synthesis by our smooth muscle cells. Then due to apoptosis of the lipid-laden foam cells, there will be this lipid debris formed over here, which will form our soft lipid coat of the atheroma. So this is how a fully developed atheromatosis plant will look. This is the fibrous cap over here. These are endothelium. These are the smooth muscle cell proliferations and macrophages, and this is the soft lipid coat or the necrotic coat, and this is the media. This is a histological view. You can see the lumen over here, and you can see these small clefts over here. These are cholesterol clefts, and they are lipid coated. Now how a normal artery looks and how an affected artery looks. You can see the lumen has narrowed down so greatly. Alright, so mind you, the process of formation of plaque can begin very early, at even the age of 12. So even your little cousin or 5 and Bola can should be careful. There are two types of plaques, stable and unstable plaque. Stable plaque will have a thick fibrous cap, which will prevent it from getting vulnerable, and the unstable plaque will have a thin fibrous cap, so it may get vulnerable to superadded changes in coronary atherosclerosis. Other superadded changes, these are superimposed changes which occur over pre-existing plaque. Alright, now these are the main cause for causing acute coronary episodes, for like MI, unstable angina, sudden ischemic death, etc. They will convert chronic stable lesions into acutely unstable lesions, and they may cause thromboembolism, hypoinfarction, sudden vessel occlusion, etc. Some common precipitating mechanisms. We have aneurysm. You can see a normal artery over here and a bulged artery over here due to weakening of the blood vessel. Then we have thrombosis over here, normal artery, local coagulation of the clot formation. Then we have intraplaque hemorrhage. We also have embolism, thrombosis and embolysis beginning over and going in the bloodstream. And then we have calcification. Some other non-atherosclerotic causes, they are sorry, they are vasospasm, compression, thromboembolism, obviously like sickle cell anemia, etc., etc. And then we have vascular trauma. Now, obviously, this topic wouldn't be complete without me covering the various clinical syndromes and constituting the ischemic heart disease. Alright. So, ischemic heart disease, it's like a group of clinical syndromes encompassing angina, MI, and you will see as we go by. Angina is nothing but the chest pain. Alright. It is guys, one of them is chronic stable angina. So, there's fixed stenosis in this, and you will feel pain on strenuous exertion due to increased myocardial oxygen demand. Then we have principal-mediated angina, which is vasospasm in an atherosclerotic vessel. This may be caused due to release of humoral vasoconstrictors by muscles and etc. And over here also you can feel pain, but on rest. In unstable angina, this is a real deal. You will feel pain on rest. There will be unstable calves, which will get affected by superimposed changes of coronary atherosclerosis. This is indicative of impending MI. Myocardial infarction, death of cardiac muscles due to reduced blood supply. You can see it is caused due to spontaneous coronary artery disease, hypercoagulable states. It can be drug induced. It can be caused due to vasospasm, or it can be autoimmune related, or also due to plaque rupture. So, very simple pathogenesis we have over here: endothelial cell injury, plaque formation, plaque rupture, reduced blood supply, ischemia, cell necrosis, and then we have acute MI. This is just an overview. You can see all those three arteries that we discussed earlier supplying the heart over here. You can see artery getting obstructed over here and then affecting the endocardium. You can see zone of necrosis developing over here, and then as we progress, this zone of necrosis is widened. Then some changes in MI. We have within 4 hours of occurrence of MI, we can see waviness of fibers. You can see these veiny fibers. Then 4 to 12 hours, you can see hyperleucinopenia and early coagulative necrosis. Within 12 to 24 hours, you will see heavy granulocyte infiltration or neutrophilic infiltration. Then within 1 to 3 days, you will see neutrophilic lymphocytic infiltration. Then on 3 to 7 days, you will see granulocyte tissue formation along with angiogenesis. On 7 to 10 days, you will see fibrous proliferation. On 10 to 14 days, you will see dense fiber scarring caused due to myocyte loss. And after like 2 weeks, you will see everywhere there scarring. Why? Because there was prolonged myocardial ischemia, and then the muscle didn't get time to heal, right? So there will be increased myocyte loss, and so heart won't be able to perform properly because these muscles, they will all get fibers. So those changes, you can see a subendocardial infarct over here, this pale area, this transmural infarct over here, which occurs throughout the thickness of the heart. Then we move on to chronic ischemic cardiac disease. This is nothing but the prolonged continuation of ischemic heart disease. So this can be characterized as progressive heart failure due to ischemic myocardial damage. Then this is the real deal, sudden cardiac death. This is like a sudden tragic end game, because within 1 hour of onset of coronary cardiac symptoms, the person will experience death. Alright, and the main important fact is that this can also be caused due to mild coronary stenosis. So the size of the blockage of the artery, that does not matter, but instead the electrical instability matters.
So that was the excellent presentation by Ms. Dilima, where she has covered the pathogenesis part and how market is involved, and not only the microscopic and the microscopic features she has shown, but she also showed you what are the risk factors which can lead to the acute myocardial infarction. So till now we have learned about the anatomy, action potential, cardiac cycle, then biological markers, pathogenesis, now the time for the drugs which are going to be used for management of ischemic heart disease. So I invite Siddiq Roshan from 2022 batch to talk on drugs used in ischemic heart disease.
Good morning again. The heart has survived the year and the heart is already strong. My name is Jalna, batch 22. My topic for today is drugs in ischemic heart disease. So learning objectives include frequent emerging pharmacotherapy and evidence-based learning rather than giving bookish knowledge that is already learned with more evidence-based. Secondly, highlight recent trials and updates from American Heart Association 25 and CMD 25. So let's suppose you are a PR and have a patient of 60 years old, male, known case of diabetes and hypertension, presented with chest pain radiating with the left arm, vital unstable, drop positive with ECG, suggestive of NTA wall MI. So what would be the next kind of management? So at the end of my session, I hope you will not be able to diagnose at Dr. House, but at least you will be able to manage this patient. Epidemiology and modeling. Classification of course treatment differs based on the classification. We have stable, unstable and variant angina. Variant angina can be clinically defined by KNN test, properly negative. And next, this image is from Goodwin and Gilman's book of pharmacology. It indicates that if there is imbalance between oxygen demand and supply, then it leads to ischemia. So these are various interventions pharmacologically we can do to survive the heart muscle. So let's dive into each drug. First we have nitrate used since last 150 years. So mechanism of action includes it inhibits cyclic GMP, facilitate with dephosphorylate MSCK kinase and hence it leads to muscle relaxation. The enzymes are predominant in males, so therefore preload is more than that of the alpha load. It also has a redistribution phenomena, also known as Robin Hood phenomena. Robin Hood was a thing which used to take money from rich and provide it to poor. So nitrate does the same work. It also has anti-thrombotic activity. These are the preparations. It could be patch, sublingual tablets. These are the areas. So there is a phenomenon known as Monday's disease. People working in nitrate industries manifest all these phenomena only on Monday. And later on when the week passes, these all phenomena of manifestation goes down. This is known as Monday's disease because of the tolerance. Tolerance can be treated by nitrate-free interval and dependence can be treated by gradual taking of the dose. There is a question for audience. Can anyone name phosphodiesterase 5 inhibitor and who uses? Yeah, so it is used for erectile dysfunction and pulmonary hypertension. So nitrate shouldn't be administered if BP is less than 90, heart rate less than 50 or more than 100, suspected RV infarction or inferior wall MI. And ECG came to inferior wall MI could be here. And say benefit taken past 24 hours or it could be 48 hours. Next we have calcium channel blockers. It is a smooth muscle relaxant and best in the history. These are the side effects. Non-DSPs like verapamil and non-selective beta blockers like propranolol can be avoided because it causes sinus depression, atypical and cardiac arrest. So rather than salvaging patients from MI, you end up killing the patient due to cardiac arrest and it will be held under 106 BNS. There is an update nowadays. We don't have section IPC for medical negligence. It is the RTO and Visa 106. The replacement of 304 section IPC. Then there is fault diagnosis. There is no point for getting exam hypertrophy. So So there's a patent drug which comes to our mind when we learn hydrocolloids, fentanyl, derivative like hydrocolloid and chemical drug. But on investigation there was no such epileptic history, and later on we came to know that it was amlodipine 5 mg for 10 years which was resulted. And there's a published research paper in PubMed in 1984, that is 30 years ago, and it is resulted amlodipine 5 mg. Next, beta blockers. The only drug which reduces mortality by 20%, and we are already diverse. ADRs of beta blockers have been learning since our childhood: ABCD, bradycardia, asthma, CHF of acute bronchitis, diabetes mellitus. Beta blockers are contraindicated vasospastic angina. I hope you know the reason. Again, there was a published research paper in American Heart Association which concluded that in patients with angiographically documented stable CAT without heart failure or insulin demand, beta blockers are associated with significant reduction in composite of all causes of mortality, hospitalization, or next, we have neurolentil short and sweet. Mechanism of action includes activation of H3 sensitive potassium channel or hyperpolarization relaxation. It has ADR like cancer also, and IO-NK trials conducted found that therapeutic effects are decreased in unstable enzymes. Newer drugs includes dark alcohol, which causes reverse Robin phenomenon as that of hydrate. Evapradine, it blocks funny sodium channel and decreases visual acuity. So when the reasoning is from light-to-heat, the same sodium funny channels are also present in retinal cells. So if the conduction is delayed, it can help in decrease in visual acuity. Recently, it has been approved for CHF. Antimetabolites, like we are not focusing on oxygen demand and supply, but inhibit the fatty acid metabolism because it consumes a lot of energy compared to carbohydrates. So we have ranitidine, trimethazidine, and fasciclovir. These all inhibit L3 CCAT channel, and hence they are increasing from carbohydrates. Then dual antiplatelet therapy. We have aspirin and NEP2Y inhibitor. So there is a comparison between clopidogrel, fasciclovir, and beta-blocker. And there was a study in May 2020 which was meta-analysis of 52,000 patients from 12 RCT, which concluded that of course the efficacy and potency of beta-blocker and fasciclovir is higher, but then bleeding tendency is also higher. And in Indian scenarios like developing countries where financial constraint is there, we will prefer clopidogrel as compared to beta-blocker. Otherwise, we have ACE inhibitors, statins, and aldosterone antagonists. Analgesic treatment option. This image is from American Heart Association. With the step-down criteria, we go for nitroglycerin, sublingual, then IV, then morphine, then fentanyl. These are the newer emerging therapies, which include JIIU benefits beyond glucose control. Earlier it was only for diabetic patients. There was Odyssey trial 2022, which indicated that CCCSK inhibitor decreases mortality, and beta blocker benefit is consistent with preserved. These are the new interventions in health treatment and evidence gap. So as you will be able to diagnose this patient. If not at all anything, you can at least learn the mnemonic Mona rash, which includes morphine, oxygen nitrate, aspirin. Then we have ticagrelor, beta blocker, statin, and etc. These are my references.
So it was a very nice presentation. Can you name the references she has used for preparing this seminar? What are the books she has referred? What are the images she has shown for the books? Pharmacology book. She mentioned the international publication of the book. Goldman and Gilman. कभी देखा है बुक? Higher level. Yeah, it's one of the standard textbooks. She has referred American Heart Association. She has referred Tripartite book. she has referred the internal medicine by Harrison also. So we need to go through a lot of knowledge, and there are various sources. The knowledge present in the books is abundant, but the amount of knowledge present in the brain is hardly 0.0001%. So it is expected from undergraduate that there is some kind of must-know knowledge. So you need to find out from each subject what are the things undergraduate should know must, and there are certain things which are undesirable. If you know or you don't know, that will not be problem. So now we go to the next presentation. Now till now we have gone through the drugs also. Now how a patient of acute myocardial infarction or ischemic heart disease will present to you when you sit as a cardiologist in your clinic. So to talk on that topic, we have Ishaq from 21 batch. She will talk on the clinical presentation.
And the radiation, as you know. So the next is
failure, which increases the end diastolic pressure, which produces S3. S4 is due to myocardium become fibrotic and less compliant. So the heart atrium needs to contract harder to fill the stiff ventricle that produces S4. Decreased intensity of S1. In left ventricular failure, there is increased volume of left ventricle due to impaired contractility of left ventricle, as we know. So there will be mitral valve regurgitation, which produces soft S1. Here the murmurs are functional murmurs, which are when the ischemia of capillary muscles that causes acute severe mitral valve regurgitation, which produces late systolic murmur. Raised temperature is due to when the dead cells of cardiac myocytes, they releases the enzyme, intracellular enzymes, which produces cytokines. Decreased volume of carotid pulse is decreased systolic blood pressure by 10 to 15 mmHg. That is due to hypotension. And transmural ischemia, there is entire wall thickness affecting that causes local inflammation of overlying pericardium, which produces pericardial frictional rub. Here the triad of symptoms present in inferior wall myocardial infarction and posterior wall myocardial infarction. Thus hypertension in this inferior wall and posterior wall involve right coronary artery, which supplies the right ventricle. There is decreased contractility of right ventricle and impaired diastolic filling, which causes raised in GDP and immediate contractility causing hypertension with clear lungs. Anterior infarction leads to sympathetic hyperactivation causing tachycardia and hypertension, whereas inferior infarction causes parasympathetic hyperactivation, which leads to hypertension and bradycardia. These symptoms are more of like complications, seen in complications of MI. So the next we will see, we have to, for the severity of angina, we have Canadian Cardiovascular Society Functional Classification. There are 4 classes. Number 1 is class 1, ordinary physical activity does not cause angina. In class 2, there is slight limitation of ordinary activity. In class 3, marked limitation of ordinary physical activity. In class 4, there will be inability to carry out any physical activity without discomfort. Angina and discomfort will be present at rest even. So, and the next is heart failure will be occurring in the severe cases of MR. So here just the symptoms which are present in heart failure. Left ventricular failure of left ventricle to pump blood into systemic circulation, which causes dyspnea, orthopnea, PND, and fatigue, exercise intolerance, cold extremities. Whereas right ventricular failure causes pedal edema, hepatomegaly, ascites, weight gain, fatigue, and exercise intolerance. Now, the patient is coming to you with chest pain. How will you differentiate that pain is cardiac, respiratory, or GIIU or any miscellaneous pain? So, the most important thing is character of pain. You have to see the character of pain. In cardiac pain, there will be pressure, heaviness, or squeezing type of pain associated with like sweating, palpitation, dyspnea, and nausea. Whereas in RS, there will be sharp, stabbing, or pleuritic pain, which is associated with cough, dyspnea, or fever. In GIID, there will be burning or sour pain, which is associated with regurgitation, bloating, acid reflux. So these are the differentials of pain. That's all from my side. Thank you so much.
So that was a fantastic presentation of Fatima. We know when she got the presentation related in the morning, but she sat for 1.5 hours and she prepared this presentation and delivered in a very nice manner. So we have such talent in our college. The only thing is that we need to push it. So once अभी मैं उनको आवाज दे रही हूँ for the chest pain हो रहा हूँ. So I thought whether it is a chest pain with MI or without MI. So it came to my mind that it is chest pain without MI. Can you name the condition where there is a chest pain when the person is coming on stage and having chest pain without MI? So next presentation is by Mary Shea from 2021 batch. She will talk about the investigations done when a case of IIT is present to the clinic. First you need to hospitalize the patient and then you have to investigate to rule out whether it is cardiac origin, whether it is respiratory origin or it is from GIT tract. So that there should not be diagnosis. I remember one of my teachers from biology from Parvani. our daughter studied here also, that he got chest pain and he was taken to the hospital and everybody thought that it is a myocardial infarction. But when they did ECG and the cardiologist he examined, he found that it was because of the gastric regurgitation, not because of the myocardial infarction. But that is a different story that he died of MI after some period of time. So now next we have the investigation and it will be delivered by Ms. Mary Sheikh from 21 levels.
Assalamualaikum everyone, myself Mary Sheikh. Today I am going to talk about how we figure out what's going on when someone's having a heart attack. Let's start with a quick case. A 60-year-old man walks into the emergency department with chest pain. Now this case shows that how symptoms that one chest pain can point out to many different things. That's why investigations are so important. Because let's be honest, heart does not always scream for help. Sometimes it just whispers, and as we doctors, it's our job to listen to it carefully. And investigation helps us do the same thing. Starting off with our best friend in the emergency room, that is the ECG or the electrocardiogram. Basically, it is divided body into two things, that is the resting ECG and the stress ECG. In the resting ECG, when the patient is having chronic stable angina, if the patient is asymptomatic, there won't be any ECG change. But if the patient is symptomatic, there would be ST depression seen on the ECG. In the STMI, the earliest finding in the ECG would be the increased amplitude of the T wave or the hyperacute T wave. Second is the T wave inversion. Third is the ST elevation, which is convex upwards. It gives the Clare sign or the crown stone appearance. ST elevation more than 2 mm at the gym, finding at least 2 molecules, 3 quarter leads, and ST elevation more than 1 mm in the adjacent leaf leaves is significant. Then we have the deep Q wave. The depth of the Q wave is directly proportional to the volume of the tissue depth. Now here you need to remember that once you start with the reperfusion therapy, all the ECG findings will come back to normal, but this finding, the deep Q wave, will persist for the whole life and it represents the whole myocardial infarction. Next is the non-progression or the poor progression of the R wave. Normally what happens is, in the normal individual, the amplitude of the R wave keeps on increasing from V1 to V6. But here, since necrosis happened and there is so much of infarction, there is so much negativity in the heart, which causes the R wave, which is the positive wave, to increase slowly. When we have ST depression and T wave inversion, the ECG that actually does not tell us about the non-STMI or the unstable angina. We need troponin test to differentiate between the two. Here in the first diagram, you can note that there is ST elevation in the lead 2, 3 and ADS suggestive of inferior wall MI. And as I said that on the ECG, ST depression and T wave inversion cannot differentiate between the unstable angina and the MI, non-STMI. As I said, there is exercise ECG here. This is performed in those patients who are asymptomatic but had chest pain prior. So you actually make the patient work on the treadmill, while you gradually increase the speed and inclination of the treadmill every 3 minutes. The objective of the test is that the target heart rate should be achieved, and the target heart rate is 85% of the normal physiological value, that is 220 minus the age. The inference is that if the target heart rate is achieved and there is no ECG finding, that means coronary artery is not blocked. But if the target heart rate is not achieved and there is ECG finding, then that is suggestive of the coronary artery blockage. The ECG finding you will find here is the downsloping ST depression or the horizontal ST segment. The ST depression should be more than 1 mm for more than 80 milliseconds, that is 2 small squares in the ECG in the at least 2 contiguous leads. There you can see the downsloping ST depression and the horizontal ST segment. Moving on to the cardiac markers that have already been discussed. Chest X-ray can also be used. You can see cardiomegaly, pulmonary congestion or edema, if there is acute left ventricular failure and aortic stenosis and calcification can also be noted on the chest X-ray. Moving on to the echocardiography, it is also of 2 types, that is the resting echo and the stress echo. In the resting echo, in the STMI, you will be able to find motion wall abnormalities. Now, why this motion wall abnormalities it is seen? Because the heart, myocardium is not getting This law can go into cerebral vessels, thereby leading to stroke. You can also know the pericardial effusion and the mitral regurgitation. As I said, stress echocardiography, while doing stress ECG, you can also perform stress echocardiography. Here you will be putting regional hypokinesia. As I said, due to low perfusion, due to the blockage of the coronary artery, the myocardium is not getting enough of blood supply. That is why that part of the heart which is not getting enough blood supply is hypokinetic. Therefore, that is you will see regional hypokinesia. It has better specificity than the ECG specifics. Moving to the coronary angiography, is the gold standard investigation. It provides real-time visualization of the coronary flow. It evaluates the size, percentage, and the number of blockages. The approach is the transradial or the transfemoral. Transradial is preferred more. Procedure is you put the guide wire through your regional artery. It goes literally through the heart and it reaches the arch of the aorta to the root of the coronary artery. So the root of the aorta and then to the origin of the coronary artery. It visualizes the severity and anatomy of the coronary stenosis. There you can see the lesions. The first diagram you can see the right coronary artery is stenosed. This thingy is used to actually after reperfusion therapy it is used to check whether the reperfusion therapy is successful or not. Cardiac MRI can also be used for investigation. Nuclear imaging such as thallium scan, thallium or system scan, myocardial perfusion imaging. In the thallium scan, you will be noting a cold spot. Why there is a cold spot? Because there is decreased uptake. Due to decreased blood flow, there is decreased uptake. Therefore, you are seeing the cold spot. In the myocardial perfusion imaging, you actually make the differential between the stenosis. Before the stenosis and after the stenosis, you see the blood flow. The differential can be noted by the gamma camera, which is inserted inside. Third is the gadolinium enhanced MRI. Just make you notice that the gadolinium does not percolate in the normal myocyte, but if it is percolating, if it is positive, that means that part of the myocardium is infarcted or it is necrotic because the tight junction is transferred there. Obviously, there are more advancements in the investigation, that is the fractional flow reserve during angiography and CT-SFR, which is used along with the CT angiography. As we say, there is no point of crying on this failed mill. So, is there any investigation which can, predict if the atherosclerosis is happening in early 30s and 40s? Yes, we doctors have already bought such investigations, and these are the important markers of atherosclerosis. HSCRP, which is positive, it predicts the future coronary events and is a single best test to detect the coronary artery. And I am proud to say that our hospital is also working on this. Evaluated total cholesterol, high lipoprotein A and upper lipoprotein B. If the ratio is increased, it increases the chance of coronary artery. And as we Indians are more prone of developing atherosclerosis and thereby the coronary artery disease, obviously due to our eating habit, also one of the genetic conditions which is running in we Indians, that is the homocysteine, which is an autosomal recessive condition which leads to increase in the homocysteine level, which causes premature atherosclerosis. Obviously, decrease in the HbA and increase in the LDL causes increase the risk of atherosclerosis. There are certain radiological investigations to check whether the plaque is vulnerable or not vulnerable. That is the CT angiography, NTCT scan, and intravascular ultrasound. Now, just remember that in the NTCT scan, you can also note the calcification and Abduction score is used to determine the severity of the calcification in the coronary arteries. My talk would be definitely incomplete if I don't talk about the AI in the investigations. Yes, there are AI in the investigations of the ischemic heart diseases, that is the AI assisted ECGs, AI integrated CD angiography, AI
So that was a very nice presentation. We know that this era is era about the investigations. Before the clinician sees the patient, they prescribe a list of investigations. That is the era. Because no one is interested in clinical examination of the patient. Before the patient is admitted to the hospital and they get a call from resident that yes, so and so patient is so and so symptoms has admitted, there is a protocol from each hospital that they go for a long list of investigations. So you can see that IIMSR gave a very long list of investigations, and also she has done a very important part, that is AI used in healthcare. I have attended a seminar in MIT Aurangabad College. They have arranged one seminar use of AI in the healthcare. So they have said that imaging field or radiology is the first field in which there is very much high use of AI. So whoever learns with AI will be the future practitioner. So now, next two presentations are from the our young doctors, Dr. Luthia and Dr. Shifa, from 2020 batch. They have themselves volunteered to do the presentation in this seminar. Otherwise, I was not being informed their batch because they were very busy with the duties of internship. But they came forward, so I was very happy that in spite of their busy schedule, they have taken some time and they are with us. So we have Dr. Luthia Mustawala. She will talk about the management of ischemic heart disease.
Assalamu alaikum everyone. Good morning, respected judges, faculty members, and my fellow colleagues. So I am Dr. Luthia Mustawala. I am an intern, and I have seen it all in the medicine posting. A man clutches his chest, beads of sweat on his forehead, and it's a moment of panic. But as clinicians, it's also a moment of decisive action. So today we are diving into management of ischemic heart disease. It's not just the science, but the story from a collapsing artery to a relieved myocardium. I hope I am able to walk you through the decisions that save life. So today's agenda is a brief overview on IIG, 3 case-based scenarios, and summary. So what is IIG? Well, it's not just a disease, it's a global killer. Now, it's a mismatch. Heart demands oxygen, but the arteries kind of fail to deliver it. Now imagine the cities where traffic lights suddenly stop. What would happen? Chaos. That's what happened in IIG. A supply-demand disaster in most of our vital organs. Think of IIG as a sliding scale almost. At one end, you have your coronary artery disease, stable enzymes. At the other end, you have your acute coronary syndromes. Now, at one end, you have your semi, a ruthless sudden strike, and in the middle, you have Ischaemic and unstable angina, the gray zone where the vigilance will make all the difference. Now, imagine ACS like a crime scene. Okay, bear with me. Now, in STEMI, the artery is completely blocked. The criminal is still holding the gun. In STEMI, the damage is already done, but the blockage is still partial. Evidence is there. And in unstable angina, the threat is real, but the shot hasn't been fired yet. So, how do you catch this culprit? 3 things. The story, chest pain, the signature, ECG changes, and the footprint, the troponin leak. You need at least 2 to convict the patient, to convict this criminal. But always consider the context. A good history is your flashlight right up. So current universal definition of ACS or acute myocardial infarction is myocardial injury and at least 1 out of 5 clinical evidence of myocardial ischemia. Symptoms, new ECG changes, development of pathological fluids, imaging evidence, that is a new regional wall motion abnormality, and angiography evidence. So next, let's move on to the case-based scenario number 1. It's a relaxed night in casualty, and suddenly this patient comes in barging. He's a 58-year-old male, crushing rectosternal chest pain, diaphoresis. You are worried, you check his vitals. He's hypertensive, he's braddy, his tachypneic, his SpO2 is dipping. Now, you've seen it all before. This is not a drill for you. What would be your next step? You take the ECG. When you take the ECG, you see this. There's ST elevation in 2, 3 and area with reciprocal changes and opposite changes. What is it? From all the past lectures. This is an inferior wall Ischaemic. Now at this point, tendon of the T is the muscle and your countdown it starts right now. You administer the loading dose and atorvastatin 80 mg. Then comes the battlefield decision. If you can get him to a PCI capable center within 120 minutes, you go for primary PCI. If not, you don't wait, you formalize the patient within 10 minutes using either tenecteplase or reticule. And then you transfer the patient to a PCI capable center. You check for the ST resolution after at least 60 to 90. Let's say it is under 70% resolved. That means your thrombolysis was unsuccessful. You have to open ST PCI and emergency PCI within 2 hour time. And if it was successful, you go for a pharmacoinvasive approach, that is you perform PCI within the 24-hour time range. Now, I mentioned loading dose. What is it, this loading dose? It goes by the acronym MONAD. There's morphine, 2 to 4 milligram IV slow doses. There's oxygen, 2 to 4 liter per minute via nasal prongs. There's nitroglycerin, 0.3 to 0.6 milligrams sublingual every 5 minutes maximum. You can give it 3 times. There's aspirin, 150 to 300 milligrams chewable, and there's clopidogrel, 600 milligram loading, or other medication. Now, is your work done? No, it's not. Because there's more to it. You have to monitor the patient. Okay? So you monitor, you check the vitals of the patient, you access the site check, you see the ECG, under rhythm monitoring, you see the urine output, because there's something known as contrast-induced nephrocalculator. And after that, what would you do? You talk to the family. Because this is where your AdCom would come in handy. And well also because medicine is not just about fixing the vessel, it is also about rebuilding that trust and having a patient relationship. Now, you counsel the patient about medications he has to take. So, antiplatelets, dual therapy for at least 12 months, statin, rosuvastatin, 20 milligrams, high intensity, lifelong, beta blockers, ACE inhibitors, and aldosterone if there are significant risk factors or if it is indicated. So, after that, you follow up with investigations and labs and lifestyle rehab. This was about the first case scenario for the classical steroid. Let's move on to the next case scenario. Well, it's Monday, you're in OPD, we know it's a hectic OPD on Monday. Now, you meet your patient, Mrs. Veena Kulkarni, 65-year-old female. She has chest pain, which is very typical of MI. She describes it, and you think, well, it's MI. And then she says one thing. She says, well, it got resolved around 20 minutes or so. You are thinking, okay, let's take an ECG, let's see what it is. This is the ECG. And after seeing the ECG, you're kind of confused. Sensed MI could be unstable angina as well. What would you do? You check the serial components. That is your tiebreaker for the serial. So when there is a serial drive in the component level, it is over the diagnostic tensor. Then say the troponins are negative. And as the patient in this case said, it was a transient pain, it is unstable angina. Now, IIMSR is how would I describe it? It's like a clever enemy. Subtle but dangerous. So what would you do? You admit the patient to monitor bed, you do oxygen, you give Mona, morphine, oxygen, nitrate, aspirin, you do clopidogrel, statins, high doses like atorvastatin, 80 mg, beta blockers, anticoagulants. Now, IIMSR is not serious, it's just quietly leaves this. After you've done your initial thing, you move on to the risk stratification. You use to be risk score. Now, if the risk is, let's say, a very high risk, you do angiography or PCI within the 2-hour time frame. And if it's a high risk, then still you go for the angiography along with you go with PCI within the 24-hour time frame. If it's a low risk, then medical therapy and early outpatient stress test. If it's an intermediate risk, you consider the early invasive strategy. For Ischaemic, as I said, anticoagulation, enoxaparin, early invasive strategy within 24 to 72 hours, you do coronary angiography, PCI and CABG. For unstable angina, if low risk and troponins are negative, and by troponins negative I mean serial troponin negative, you do conservative approach. Nitroglycerin drip, which is a drug of choice in this case, abscessional, beta blockers, enoxaparin, morphine, oxygen and aspirin. You optimize the anti-angina and risk factor modification and outpatient stress testing before the discharge. Okay, so this is the last case-based scenario that I have been discussing. Okay, now let's shift the gears. You meet Mr. Jalna. He is 58 years old, chest pain only on climbing stairs, relieved by rest. This is a very textbook of something. Stable angina. Now, this is your chance to, play preventive cardiologist. You control this would be the investigation, and these are the investigation findings that you do. So, as you see, in this patient there was dyslipidemia as well. So, what would you do? You control his BP, you tame his lipids. You're not just treating him, you're reprogramming his heart's future. So, stable angina on effort, you do a stress test. If it turns out to be positive, lifestyle modification, short-acting nitrate, secondary prevention. Let's say there was no optimal response. Go for beta blockers or calcium channel blockers. High risk is there. Go for invasive coronary angiography. You consider revascularization. PCI and single vessel disease, multivessel less than 65 years, unsuitable anatomy. In CABG, multivessel more than 65 years, unsuitable anatomy and diabetes. So, for the summary, so how do you treat IIMSR? Follow the story. You trust the ECG and you respect the troponins, and most of all, know when to fight and when to leave. So, there's clinical features of ACS. You take the history, physical examination, investigation, ECG and cardiac enzymes. Let's say the ECG has ST elevation or new LFB or true posterior myocardial infarction along with positive enzymes. This is an ST elevation myocardial infarction. It was also commonly known as Q-waves. Let's say it is ST depression or diffusion burden. Then you see there is positive enzymes. It is NSTMI, commonly known as non-Q-wave. And if there is negative enzymes, that means it was unstable angina. And let's say ECG was normal, there was negative enzymes, then you consider alternate diagnosis because there are various causes of chest pain. So the key takeaway here is just one second. Remember, STEMI needs speed, STEMI needs strategy, unstable angina needs safety net, and stable angina needs sustainability. So heart doesn't need, but if you are prepared, at least you won't panic. You'll be able to perform better. So thank you. That was it from my side.
So that was a very excellent management of the IHB by Ms. Lufia. Now we have next presentation is on complications. Once there is IHB, sure, definitely there are going to be some complications. So Ms. Shifa Rani from 2020 batch, she will talk very briefly about the complications and its management due to ischemic heart disease.
block and complete heart block. Management and prognosis of conduction blocks depends in part of the location. That's why we have divided into in cases of the interior wall or anterior wall. If secure 30 block after the setting of the interior wall it is usually the location is proximal to the AB in 90% of the cases. But if it occurs in anterior wall it is usually distal to the AB. While the QRS complexes are usually narrow in interior wall MI and the anterior wall MI, there is QRS complex is usually wide and unstable.
150.
In interior wall MI, but we have sinus bradycardia, first degree AV block, second degree AV block. First and second degree AV block are usually transient and does not need any treatment. When it comes to complete AV block, it develops in a progressive fashion from first degree to then second degree and then third degree AV block. Usually the QRS complex is narrow and it develops over a period of time. When we proceed to the anterior wall MI, there is the first degree AV block, second degree AV block. In cases of interior wall MI, the second degree AV block is Mobius type 1. But in cases of anterior wall MI, it is usually type 2. What is the difference between type 1 and type 2? Type 1 is there is a progressive prolongation of the CR interval, and while in type 2 Mobius, there is a fixed CR interval. And next is complete heart block. And complete heart block in this setting of the anterior wall MI usually develop abrupt in first 24 hours. Management differs. So patients with anterior wall MI, usually cardiac pacing is required. If in cases of interior wall MI, the patient develops conduction loss. So first we have to the patient is hemodynamically stable or not. If patient is unstable, how we can get patient is unstable? If the patient is having hypotension, alternative status, signs of shock, or ongoing chest pain, pulmonary edema. So we will tell the patient is having kind of hemodynamic instability. So in these cases, we will give the patient hydrogen in the doses of 0.6 to 1.2 milligram, or we can proceed with if there is a hemodynamic instability and conduction loss persists, then cardiac pacing may be required. Beta should be avoided. Then, in cases of the stable interior wall patient, second and third degree AV block, there is continuous ECG monitoring is required. If acute myocardial ischemia outcome and proximal vascularization may be needed. First degree AV block, there is no need or these patients do not require any specific therapy if they are hemodynamically stable. Then we will proceed to arrhythmia. Arrhythmia should be supraventricular arrhythmias or ventricular arrhythmias. Arrhythmia is because of the need caused by inhomogeneity of ischemic myocardium. So supraventricular arrhythmias in which we have sinus tachycardia, premature atrial release, ESC, atrial flutter, and atrial fibrillation. So sinus tachycardia is because of anxiety, persistent pain, atrial dysfunction, fever, hypotension, and hypovolemia. Premature atrial release are because of atrial ischemia and tachycardia. ESCE is usually transient in this setting and usually needs deep leg control using cavity massage, adenosine in doses of, as you remember, 6 milligram and 12 milligram it contains. Then vertebral beta block, atrial flutter and atrial fibrillation. Ventricular arrhythmia in which we have VTCs, beta blockers can be used in this setting. We have accelerated atrioventricular rhythm in these cases and ventricular tachycardia could be sustained or non-sustained. In cause of rupture and may progress to cardiac damage and death. Then इसके बाद injury का incomplete rupture. Why there is an incomplete rupture? Because it occurs when organized thrombus and the pericardium is a ventricular perforation. It may progress to the fan rupture or formation of the false aneurysm. Clinically, these patients present with the persistent or recurrent chest pain, particularly pericardial pain, restlessness, nausea, irritation, and transient hypertension. How we manage these patients? So, first of all, diagnosis. If there is a rupture, patient will diagnose in the pericardial tamponade. So, we will see the clinical and cardiographic findings. On echo, pericardial usually the evidence of chamber formation occurs. Emergency pericardial sentences may confirm the diagnosis. Management usually requires surgical intervention or emergency pericardial sentences. If there is a rupture of interventricular system, there is shunting occurs. Patient may present with mild compromise with dyspnea and exertion to severe cardiogenic shock. A new cardiac movement is usually heard when there is an interventricular septum rupture. So these are usually harsh, loud and transitory, radiating towards the right atrial body, which is present in 50% of cases. Usually surgical repair is required. In cases of capillary muscle rupture, usually occurs 2 to 7 days after the implant, resulting in acute mitral deterioration. The patient is present with the hypotension, pulmonary edema, systolic pulmonary, which is generally not present in these cases. Management is based on prompt initiation of medical and emergency surgery after the reduction is required using nitrate, sodium hydroxide and diuretic. And inotrodes and vasopressors are required. Surgical intervention can be changes the treatment of change. Next, we proceed to the pericardial complication, in which we have pericardial early infarct associated pericarditis, post-MI pericardial effusion, post-cardiac injury syndrome. First is pericarditis, early infarct pericarditis, post-infarct pericarditis, which could be a morbid death. Clinical presentation, patient present with a pericardial fistula and chest pain. Usually, there is a self-limited condition, anti-platelet and anti-coagulation therapy should be continued. On if patient land up with pericardial effusion, it is usually seen in the early course of transmural infarct, usually asymptomatic. Patient may present with the tachycardia, even in absence of planned hypotension, may indicate significant hemodynamic compromise. So, pericardial sentences may be required. Post-cardiac injury syndrome, pericarditis is actually pericarditis with or without the pericardial effusion, resulting from the injury to the pericardium constitute ER. There is a latent period, it includes Jalna syndrome and post-traumatic pericarditis. Jalna syndrome is nothing but it develops, it is because of immunologically mediated reaction to the necrotic muscles. It develops 2 to 10 weeks after the infarction. Patients were present with the fever, chest pain, and friction. Lab findings were made with the leukocytosis and rare markers of inflammation. Embolic complication, as we know, there is a thrombus formation occurs. Because if there is a decreased myocardial contractility, it may cause a static. Already there is endocardial. It creates a surface for thrombogenic system. So there is thrombus formation. So it may land up in the systemic embolism, pulmonary embolism. So it may result in stroke or renal infarction. Next is cardiogenic shock. The patient and heart rate. Persistent hypotension with the SpP less than 18 mmHg of mercury for more than 30 minutes in absence of hypovolemia. It occurs usually when the myocardium is more than 30 to 40% of the it results in cardiac dysfunction. Other ventricular remodeling working there, so it may lead to progressive heart failure. Causes usually extensive myocardial damage, arrhythmias, hypovolemias, and mechanical complications. Management depends on the individual. The goal is to restore the perfusion and cardiac function. Deperfusion is strategy and
study presentation by Shifa Lani on complications and its management. I have one question for you. It is a field of maths, isn't it? So you have to answer me. Dash is better than cure. Dash is better than cure. Prevention is better than cure. Dash is the only treatment. Dash is the only treatment. Prevention is the only treatment. So now we have come to the last part of this seminar, that is prevention of ischemic heart disease. That will be by Professor Anup from 2021 batch. She will be talking about how to prevent. The best part of the presentation is to prevent the disease. So we epidemiologists are always behind that no one wants to suffer from disease. So that ये clinicians वाला का धंधा नहीं करना चाहिए, ठीक है? So now we will talk about this, and after that we have certificate distribution for the infographic competition we had last year, and also the prize distribution for this seminar after this, and these will come.
Alcohol should be avoided. of smoking products, and lastly, cessation programs. It is estimated that even small reduction in average blood pressure will decrease the cardiovascular complications related. It includes multifactorial approach, which is based on prudent diet. Physical activity should be a part of our daily normal life, which includes at least 150 to 300 minutes per week of moderate intensity aerobic activities like brisk walking and cycling. 70 to 150 minutes of high intensity aerobic activity per week. Muscle strengthening activities like squatting must be done for at least 2 days per week. Household chores like squatting while cleaning, climbing stairs instead of using lifts, and walking to nearby markets must be seen as opportunities. Now, a high-risk strategy includes identifying people at risk using simple tests like blood pressure measurement and serum cholesterol levels. And specific advice includes bringing these people into the preventive care and motivating them to take positive action against the risk factors. Various high-risk intervention trials were done to prove that reducing risk factors is feasible. This includes the Stanford community study, which was done to show the impact of health education on reducing the risk factors. The North Kerala project in Finland, which used strategy of mass community action and advice. Multiple factor risk intervention trial used 3 interventions: smoking cessation, controlling bleeding, and reducing hypercholesterolemia. Also tried smoking intervention trial aimed at lowering serum lipids and smoking cessation. Lastly, lipid research clinical study was a randomized control trial which used cholestyramine to reduce serum cholesterol in type 2 hyperlipoproteinemia patients. Secondary prevention is continuation of primary prevention, and its aim is to prevent the recurrence and progression of CAD. The principle is same as that of primary prevention. It includes medical interventions and surgical interventions. Medical interventions like using drugs, beta blockers, anticoagulants, nitrates, and ACE inhibitors, of which beta blockers have given the best promising results to reduce the mortality in patients who have had at least one episode of acute attack. Surgical intervention includes coronary artery bypass graft and percutaneous transluminal coronary angioplasty. CAD can be achieved with a low mortality rate of 1 to 3% in young and healthy individuals, whereas the mortality rate increases to 4 to 8% when in older patients. PDCA is now preferred by younger individuals as the first revascularization process, and it exceeds in number than CAD. The indications of revascularization process include symptoms persisting even after maximum tolerable limits of medication, more than 50% stenosis of the left main coronary artery, 3 vessel disease along with left ventricular dysfunction, and angina in post-anal patients. But the disadvantages of secondary prevention is that despite high advancement in treatment, the mortality rate remains high, with 10% risk within the first year of the intervention and 5% yearly. 30% of the deaths occurred within 30 minutes of the onset, which had led to failure of coronary care units to create an impact on the mortality rate. Thus, population strategy has greatest potential, and it is also cheaper compared to the primary prevention. You don't need to be a cardiologist to save a heart. We can just start with us. So here are some takeaway tips, because we as medicos are at risk of IIT due to irregular lifestyle, lack of sleep, poor diet, and continuous stress. So what can be done? Let's remember it is a mnemonic healthy life. Rather than leaning on what exotic things are not available around here, we can make best use of the locally available food products. Exercise. We can take rounds on the road around the campus building. We can walk to hospital and college instead of using bikes. We can also promote using bicycles instead of bikes. Avoid smoking and alcohol. Regular checkup, that is like blood pressure, serum lipid levels, sugar levels, and we should learn to tackle stress, and we should have fixed sleep cycle, increase awareness among ourselves regarding these preventive measures, and also we should learn and time management to reduce the stress. Thank you.
That was a very cool and calm presentation of IIT conception. Thank you. So now we have finished all the 10 presentations. I request all the audience, please give a big round of applause. We are taking lot of efforts to prepare this seminar, and they have come forward and they have presented well, they have prepared well, they have used the technology very well. After seeing this presentation, I came to know that Canva is one of the platforms where the PPTs can be prepared and presented because they have very high resolution. I have 2 or 3 points which those need to be in favor of this seminar. One is that nobody has kept time limit. Second thing, everybody has tried to vomit the knowledge they get.